First, I want to welcome everybody to our Learning Cafe on opioid-exposed neonates. We have the pleasure of having Dr. Mark Gaylord here with us today. Dr. Gaylord has practiced at the University of Tennessee Medical Center in Knoxville for the past 30 years. While at the UTMCK, he has advanced to Professor of Pediatrics, Division Chief of Neonatology, Director of the NICU, and Neonatal Director of the Regional Perinatal Center. During his tenure and leadership at UTMCK, the NICU has developed the first single-room NICU in the region and serves 2 other hospital systems in the area. His passion has been to improve the health and well-being of mothers and babies in Tennessee. He has held multiple community, state, and national leadership positions with the National Perinatal Association, Tennessee March of Dimes, Tennessee chapter of the American Academy of Pediatrics, Knoxville Ronald McDonald House, Knoxville Academy of Medicine, state perinatal advisory committees, with the goal of helping to improve perinatal health in Tennessee. And so without further ado, I'd like to bring you Dr. Mark Gaylord for his presentation. Oh, I'm sorry, one more other quick thing I forgot. You all are muted right now, just to make sure we don't have too much background noise. If you have a question, please feel free to put the question in the chat, and we will get that to Dr. Gaylord as soon as possible. After the presentation today, you'll be getting a survey link to fill out so we can kind of know what didn't go well, and kind of get future ideas for topics from you all. We'd really appreciate this. Recording of this will also be put up on YouTube in the weeks coming. So if you have a colleague that missed it or wasn't able to attend, or you want to just review the training, that'll be at your disposal. And also, Dr. Gaylord has graciously allowed us to have a copy of his PowerPoint. And so if you'd like a copy of it, please email Ms. Karen Gray, our administrative specialist, who sent you out the blast. And as soon as I get it to her, she'll get it to you. And so now, Dr. Gaylord.
Hello. You'll have to bear with me. Since the COVID, I've done a lot of Zoom, but not a lot of Zoom talks. So I'm hoping that Andrew will save my fanny here. I just wanted to share with you a problem that we began to see at least 15 years ago, and has until the past maybe 2 years just continued to increase. My wife gives a talk from moonshine to marijuana to drug abuse. So I think East Tennessee is well suited for this due to our good old Scotch-Irish background. But it also has a lot to do with the with poverty and with lack of opportunity. So why don't we just get going here? I know I'm talking to the choir, but you know, the addiction is a primary chronic disease. Can everybody hear me okay? Okay. It's a disease of brash reward, motivation, memory, and related circuitry. Addiction's not a new thing. The increase in addiction seems to be. It affects our neurotransmissions and interactions within the reward sections of the brain that impede self-care related behaviors. We now know from a lot of studies in the adult world that it's definitely genetic, that there are those of us that are more easily can develop that. We also know that that is passed on to our babies. We know that some babies respond very differently than other babies to the drugs we give them. The other thing that is known is that it probably and almost also changes the brain of newly born babies. And that is something that is that we are now birthing the next generation of addicts. You know, there was, if you look at the AA Big Book, it was written in the 30s. And if you look at that, you know, they talked about doing 90 meetings in 90 days. It was very interesting. A functional MRI study was done about 10 years ago. And guess when it showed that the addict's brain changed with abstinence? It was 90 days. So we know that there is definitely changes in the brain that may be reversible, and some changes in the brain that may not be reversible. So you have neurotransmission interreactions that leads to biological and behavioral responses to external cues that triggers cravings and our engagement in addictive behaviors. We'll talk a little bit about addictive behaviors. And if you talk to any addict, it involves cycles of relapse and remission. You'll hear in the AA world a chronic relapsing death, chronic relapsing disease that leads to death. So substance abuse is an individual's intentional use of alcohol or drugs for pleasure, coping, self-medication that results in adverse consequences in one or more areas of that person's life. And the level of dependence may or may not be considered addiction, may or may not be attained. So just because you drink, just because you use drugs, doesn't mean necessarily that you will become addicted. You know, in the AA world, they talk about earth people, those people that go to a restaurant and with a second glass of wine, they leave half of it empty. And that's just not something that you usually will see in an addict. You know, an addict will not leave it untaken. So what is the disease of addiction? Again, I know I'm talking to the choir. Again, chronic relapsing disease involving drug seeking and abuse by long-lasting chemical changes in the brain. It can lead to uncontrollable cravings, seeking, and use of substance abuse with such as drugs or with alcohol. You know, what you all hear in the addict world is that, you know, I know I should stop, but I just can't. And some of that leads to even nefarious behaviors that often lead in jail. So any habitual activity that interferes with a person's ability to lead a healthy life. It's destructive to every aspect of a person's life. That's why you have organizations such as Al-Anon that teach partners how to live with the disease of alcohol, and alters neurotransmission and interreactions within the reward structures of the brain. And if you have a question, please just chat it to Andrew, and he'll some way know how to get it to me. But what we began discovering in the late 60s, early 70s, more likely in the 80s, is that some of our babies were becoming addicted. And I can remember giving a similar talk when I was a fellow in Denver, Colorado in the early 80s, and saying, well, gosh, you know, if you're going to do a drug, just do cocaine. And how much we've learned since then. So a lot of our early education on this actually did come from the cocaine epidemic in the late 70s and the crack epidemic in 80s. The other thing that I think is very different about this disease of what we're dealing with now, and it's my personal opinion, it's crack cocaine, and cocaine was a disease either the very rich or poor African Americans. And the opiate disease, and especially in East Tennessee, has primarily been a white disease. And I think that's why it's kind of drawn more attention. So if you look at our statistics, unfortunately, you'll see that there are more deaths, illnesses, disabilities than any other preventable health condition. More overdose deaths in Tennessee than traffic accidents. If you have a sick thing I do is every morning, I started doing it to see if any of my patients had died, but I read the obituaries. And at least in the Knoxville paper, if you read an obituary and somebody's under 45, it's more than likely that that was either a drug overdose, or an intentional drug overdose, and so or something to do a traffic accident. So it is a major health crisis in our state and nationwide. 1 in 4 deaths due to alcohol, tobacco, or illicit drugs. And it's epidemic proportions in Tennessee, especially in East Tennessee. This just, and I hope my pointer, this just shows you NAS cases that were in 2013 and 14, and they really haven't changed. But if you look at it, this goes from west to east. And you can see that this is a disease that primarily begins at the Cumberland Plateau and follows the Appalachian chain. And if you look at the incidence of NAS, 65% is between, the interesting thing, you don't see it in Southeast in the Chattanooga area. You see it, but not near the extent that are in the Shelby. It's because African Americans have a tendency not to use opiates. They use cocaine, use cocaine and other things, but it is a disease of East Tennessee, and 65% of drug addicted babies are born from about Cleveland to about Bristol. And so we began seeing this in epidemic forms starting about 10 to 15 years ago. This just shows you close to the peak of our disease in 15 and 16, and in end of 2015, almost 1,000 cases. 16 was very similar to that. And if you look at the counties, if you get down, 7.8%, Davison 6.7%, but look at East Tennessee, 27%. So we have a very high incidence of NAS. And it seems to run along the Appalachian chain all the way to Maine. One of my good friends, Mark Brown, is a director of the NICU in University of Maine, and he's done some of the seminal work of looking at the genetics in folks in Maine. And Maine used to have the second highest incidence behind Tennessee. So why is this? Well, one, we're predisposed, probably by our genetic predisposition. Number two is that Big Pharma was very involved in Tennessee and talking about drugs like Opana and all not being addictive. And then number three is we have, especially along the spine of Appalachia, a lot of people that, with the closing of coal mines and other things are severely in poverty and hopeless. So, and this was they're not going to do IV drugs, but they sure would take a pill. So why was this important? Well, if you look at the literature on substance abuse, women have a much higher chance of becoming addicted. And there's several reasons. There's a great social stigma, especially during pregnancy, so they hide it. If they have a problem beginning pregnancy, they're going to hide that. They're worried about how they look. They're worried about babies being taken away. They're worried about the punitive parts of our system. They're more susceptible to substance abuse related interpersonal difficulties, trauma, medical consequences. If you look at acute childhood events, ACEs, almost all the moms that are in our clinics have very high ACEs. So they've been abused prior to pregnancy, during pregnancy. Many of them have a previous problem with a car accident or tooth extraction. There's a lot of information now that 5 days of a drug, if you had the genetic predisposition, can lead you off to the races. They also become dependent faster. And again, as we talked about, they have more comorbid conditions, depression, anxiety, PTSD. If you look at pregnancy in the state of Tennessee, over 50% of pregnancies, when they are pregnant, qualify for TennCare. So it's appalling. Poverty, relationships, social problems are great among our women that begin using drugs. Comorbid conditions often precede substance abuse, and these may require simultaneous treatments. Progresses to late stages of dependence quicker, associated with other problems and GYN dysfunction. And as we'll talk about and have talked about, it does lead to increased problems that we're finding more and more about of developmental delays, disabilities, physical and neurological defects. My wife runs the Vine Middle School clinic and several other telehealth in the middle of Knoxville. And the principals at a meeting one day were just all over me about what are we going to do about this, Dr. Gaylord? And we're seeing these children at school age, and it's very, very difficult. For our foster care, we went from about 2,000 kids to almost 8,000 in the last few years being placed in foster care. In our nursery, we see people going to neighbors, going to all kinds of folks because we've run out of good choices. So when a mom's pregnant, one of the easy screening tools is called the 4 Ps. Have you ever used drugs or alcohol during the pregnancy? Have you ever had a problem with drugs or alcohol during the past? Does your partner have a problem with drugs or alcohol? And do you consider one of your parents to be an addict or alcoholic? And if they answer to this simple screen, then they should be referred for further assessment. This just shows you a lot of the problems that we see with substance abuse in pregnancy, especially with our cocaines, arrhythmias, bacterial endocarditis. It's become such a major problem that most hospital systems in town are limiting it to just, you can only have one heart valve replacement. My son's an orthopedic surgeon. He gets called to do what he called pussed out hands all the time from drug abuse. 65 to 70% of our pregnant moms that deliver in our nursery are hepatitis C positive. So that increases a whole lot of costs later on. And what we're all afraid of is that if these moms are not treated, you're going to end up with more liver transplants in the next 15 years than we've ever done. Behavioral problems in the partner. We see a lot of bizarre, inappropriate behavior. We had one couple shooting up in our bathroom, stealing diapers, stealing scales. Increased incidence of child abuse or neglect in other children, unemployment, domestic violence. Many problems with their obstetric history, cocaine and other amphetamines leading to abruptions. Great increase in our births outside of a hospital. Not too long ago, we had a 28-week baby born in a hotel. Fetal alcohol syndrome, which is, we talk about cocaine and opiates and all of that. The background for many of our moms also includes an excess of alcohol. And that's a very difficult diagnosis in the newborn period. And this really scares me because alcohol is probably the most damaging thing to the brain of anything that these moms do. NAS, which we'll talk about, sporadic or no prenatal care, whole problems, poor dental hygiene, that often called meth mouth, amphetamine mouth. Unfortunately, poor dental hygiene leads to bacterial storm and can lead to preterm labor. Many of our moms, we talk about the breakfast of Mountain Dew and potato chips. I just learned Mountain Dew was invented in Knoxville. Anyway, frequent ER visits without a good prenatal care, history of incarceration, prostitution, not unlikely, very demanding in the hospital setting, and then a whole host of problems in the newborn and postpartum period. And this one, sudden infant death syndrome, is greatly increased in these moms. So this just shows you, and I couldn't figure out how to adapt my slides, so I'll have to give it to you verbally. But as you can see, this 2006, that's what, 14 years ago, 70. 14, we had 195, and that was 14, 15, 16 was pretty much our peak, about 20% of our admissions. 2017, we saw our first decline, 181 babies 19.5% of our admissions. 2018, we were down to 136, about 15% of our admissions. 2019, 112, 11%. So it is coming down, but there's a caveat to this, guys, in that this doesn't include, this just includes the babies that withdraw. And we have a lot of preterm babies that have a drug exposure history. So much now that, you know, they've changed it to where we're beginning to look at that. And the problem is that they're under, you know, 35, 36 weeks. It's very hard to diagnose NAS in the clinical ways that we do that. And what we're seeing is a changing of drugs. We're seeing a changing of drugs from the opiates, which have become much more harder to obtain, to meth, to cocaine, to other amphetamines. We're seeing a change to heroin, which has a shorter lifetime, so you have a little less withdrawal from it. And so we have to be careful that, you know, we may be improving with pill opiates, but we may not be improving with opiate-exposed neonates, the new term for this, OEN. The other thing is that this has led us to begin looking at these other drugs and what we might to do to help prevent moms with this and to stay off drugs. Tennessee led the nation in that I think we were one of the first, if not the first, to make neonatal abstinence syndrome a reportable disease like flu, like COVID, like HIV. And that really has helped us to track areas and to track, you know, places where it has become even more prominent across our state. We're also one of the first states to have a system to where in order to prescribe opiates, you have to go in and check to make sure that when that a mom or patient had a prescription before, so that you don't have mothers, doctors shopping. And that's been very, very helpful. We've also had laws passed restricting about 5, 6 years ago, we had about 50 drug clinics or MAT clinics just within the Knoxville area. There was 5 in Manchester where they have Bonnaroo. I mean, why do you need 5 in Manchester? And we had, we're now down into the 20 to 25 range. You know, we busted one of the biggest narcotic rings that was even associated with the Italian mafia. So there's been a lot of emphasis on illegal prescriptions and cutting that back in the pill mills that many places they were called. This just shows you 2018, again, beginning to fall. And then this is statewide data at the end, and down again in 2019. Again, it's still, you know, almost 800 babies. And, you know, there's probably a lot of these, there's a lot of these babies that are born under 34 weeks that we can't really diagnose as NAS that are still being exposed. About 65% of ours had been treated for addiction. We have people treated for pain, psych, neuro use. And one of our major problems in the state is our illicit prescription drug use. So just because somebody says they're going to a Subutex clinic or they're going to a methadone clinic or they're in this place or that place doesn't mean they need to be screened. And that's why in East Tennessee, we have some of the longest length of stays, because you add not only opiates, but you add benzos and other things. And then we still have the, you know, the drug of the 70s and 80s and 90s, cocaine and methamphetamines. Most of our babies are inborn because a lot of the our outlying centers, they want to try to take care of these babies. They keep the mothers in their communities and their homes, but they just don't have the wraparound services that are essential for the care of the mother and baby. You know, they don't have the social services. They don't have the nutrition services. They don't have the ability to get them hooked up into addiction programs. So the medical treatment is becoming pretty easy and easier, but all those systems that keep mothers sober and keep them out of the system requires a whole village, a whole community. And unfortunately, some of our smaller delivery services struggle with that. As I said, most of these are over 37 weeks because it's hard to diagnose in the tiny babies. So how do we diagnose it? Now, the vast majority of ours are by screens. Mothers, in their credit, are very good about admitting when they're pregnant what they're doing. And pregnancy has always been, whether it be tobacco or alcohol or other things, kind of a golden moment to treat moms, because most mothers want to do right by their babies, and most mothers want to make sure that they have a healthy pregnancy outcome. And there was actually a study done out of Chicago years ago that actually looked at what was the most important thing for a good outcome in a baby, and that was prenatal care. And so I do think it's a golden moment that sometimes we miss because we lack the ability or the capacity, really, to get these moms into an effective treatment. Average length of stay, this varies by, ours is usually 20 to 22 days, but it varies by the drug, it varies by the number of drugs, and this is a very expensive treatment. If you looked at the first years of treating of NAS, it's about 30 or 40,000 bucks a child. Presentation, often they'll present prematurely, IUGR, withdrawal symptoms, can have strokes, can have intestinal disease. Now, most of ours present because we know them, that they've popped on a drug screen, or the mothers have let us know that. If you look at the major drugs that we see for opioids, they're pitiful children. They're irritable, increased wakefulness, high-pitched cry, tremor, muscle tones, hyperactivity, yawning, sneezing. A few have seizures. They need a lot of feeding. They have a high metabolic rate. And even with that, though, that they can, it's difficult for them because they can have vomiting or diarrhea. So you have to have good nutritional management and specialized formulas. You know, they sweat. I mean, they're just like an opiate reaction in adults. You know, this, before the COVID, this was such a, you know, in our nursery, we have 8 or 10 a day. And we had to go by, if any of you have had children, I call them mamaroos. They're the type of swings that are like looking like somebody in an astronaut, and they go back and forth and up and down. And we have a whole host of cuddlers that sit and rock and feed. These are very difficult babies for people, of even trained and skilled people, to take care of. For us as clinicians, it can mimic other things. That's why history in the mom is very, very helpful. Detail, a very detailed, you've got to ask, and you've got to be suspicious if you have the symptoms that we've talked about before. Clinical manifestations, maternal and neonatal, these are only about 50%, the urine drug screens, but either umbilical cords and meconiums are very specific, 95 to 97%. We're now using primarily umbilical cords. There are some umbilical cords that are negative that we send meconium to, but the thing about umbilical cords at NICE, that if you have a baby begin to have signs and symptoms of withdrawal, and nothing is, if nothing was sent on the mother, we save these cords for a week, and so we can send the cord after the symptoms begin. Which once the meconiums pass, we don't save the meconium. So how we treat these babies has to do with the severity, and it's a clinical score. Finnegan has made a life's work of her system of neonatal abstinence scoring system called the Finnegan score. Most babies are 2 to 3, just a normal infant. Occasionally, if you really make them mad, they might go to 5 to 7. The babies, when we begin treating, are usually if they have 2 scores greater than 10. And you know it, it's not a hard diagnosis. But we have tried to do this in a, we have used the score the nurses do. It's now online. And we have training for our nurses so that they can, video training and clinical training, so that there is, since it's a clinical system, so that there is confirmation across nurses. So you don't have one nurse that everybody's irritable or another nurse that nobody's irritable. So we train them extensively about this, because the way we've learned to treat these babies is on a nurse scale and a nurse escalation of their drugs and a de-escalation of drugs. So they don't have, the nurses don't have to wait to get a doctor's order. They can begin, it's a protocol, and they can do that up and down to quickly try to capture the babies to treat them. Okay, now I got to go to my next one if I know how to do this. Sorry, it was too large to, okay. Sorry, it's too large to send in one. Okay, now let's get back. So how do we treat these babies? For centuries, the non-pharmacologic management of NAS was recommended. And we try to do this, and there's some new standardized treatments that we're beginning in our normal newborn nursery. Things that moms do, instinctfully swaddling, rocking, minimal sensory stimuli. It's very interesting, since we've entered into all this treatment of these babies, we now have a cry room for our nurses. We have a room specifically set up that the nurses can go and sit and relax, because it's a difficult job of taking care of these babies. They need high caloric intake. They may, and it's something I don't understand, some babies will eat you out of house and home, then other babies just won't eat. And I'm seems to be more related to the benzos, but it's very difficult to tell. This has been known, especially from the folks in the Orient. One of our senior partners was from Thailand, and they smoked a lot of dope there, and breastfeeding. They never treated these babies. All the mothers breastfed. Problem with breastfeeding is if you stop or if you miss a couple of feeds. We don't like to breastfeed if the mothers have cocaine or amphetamines, because that is passed into breast milk and can lead to things such as stroke and other IVH. And then the other interesting thing, you can breastfeed with Hep C and Hep B. Not so with HIV, we think. If you go to the third world, they do that. They do breastfeed with HIV, but in the United States, that's pretty much a no-no. So the goals is to stabilize these babies and restore to normal newborn activities. There's no agreement on which score to do. We've done several statewide projects, and I think most of us use 2 10s with the escalating Finnegan scores. This is interesting, is that there's no good studies if it matters in long-term morbidity, but it sure matters to the babies and to making them more comfortable. It's not, it's very interesting that I learned through all of this, is that very few people die from withdrawal from cocaine or opiates. The one thing that people die from is withdrawal of alcohol. So these babies don't die from this, but they sure are miserable. If you look at the stimulants, you don't get the typical abstinence syndromes. I remember when I came to Knoxville in the mid 80s, the nurse practitioners would talk about babies that had the sniffles. And we really didn't, we had no idea. And I think it's because moms that were doing cocaine. The other thing is that we see, and something that's similar to this is, you know, we have moms in East Tennessee that withdraw from cigarettes, caffeine, and coffee. I had a mom drinking 10 pots a day of coffee, or drinking, you know, 10 or 12 Mountain Dews. So there are other things that you can withdraw from that aren't the typical. And maybe, at least cigarettes, may be the most common long-term problem that we have. For the stimulants, it's usually 1 to 3 days. You can see the symptoms here. It varies on how many show drug effects. It depends on the last use, depends on the drug used. They can have, we've had babies that have had seizures, we didn't understand, are very irritable with a history, and they have abnormal EEGs that tend to get better over time. You do withdraw from antidepressants, almost all of them, and it, again, depends on how many, and it depends on the dose. And we began to see these when it became much more common. About 25% of the mothers in our practice are on some type of SSRIs. And as you can see, jitteriness, shivering, fever, several hours to several days. You want to try to lower the dose during pregnancy. Again, you want to make sure that you don't sacrifice mother's health. And Paxil seems to be the best for breastfeeding. This is the big one in East Tennessee, just because it became so common and so, you know, available. The main ones that we would see are oxycodone, hydrocodone, methadone. Fentanyl, unfortunately, has a very high OD rate. And now many of our mothers are on Subutex through clinics and withdrawal programs. You know, it was the University of Tennessee Medical Center, Dr. Towers, Craig Towers, who was the first to look at withdrawing women in pregnancy. Many years ago, it was a no-no. If you actually looked at that literature, it was less than 20 patients that had that was reported on. Craig was brilliant and noticed that if you're admitted to the jail, you got withdrawn, and those babies didn't die. So his study looked at about 300 moms. 100 of them were women in the jail. About another 100 of those were in his clinic and with behavioral health, and another 100 were in other clinics where they lowered the dose of the drug but did not offer behavioral health. And guess what? Which ones got better? The ones that really showed the best were the ones that were withdrawn slowly during pregnancy, and the ones that got behavioral health. And that's a take-home point, at least for me, because substance abuse is not a problem just a pregnancy, it's a lifelong problem. And mothers need to be treated. The best time to begin treatment is prior to pregnancy. The next best time will be during and after pregnancy. So if you get my drift, they need to be in some type of program throughout. There's a lot of disagreement about medical assisted therapies, and I have my own bias in that. And the reason is I'm beginning to see second and third babies on that withdrawal in my nursery. I'm also concerned about the literature of life-changing problems that it changes in the brain. So I think that the best treatment of moms is to slowly withdraw them during pregnancy and to try them after pregnancy to get them off their drugs. Drug-free life, if not lifelong treatment, you may help the mother, but you're still going to have generations of brain changes in babies and still have 30 to 40,000 per baby in the nursery. This just shows you when you can see the times of the symptoms. This is what they look like. They're coming off the bed, they shriek, you can hear them down the hall. They're difficult to feed. You know, they're just difficult babies to manage. Many and most of our moms, unless they're in a clinic where they're being, not only where their medical needs are being met, but their psychological and addiction needs are being met, are abusing multiple drugs. We don't even look at, you know, tobacco, caffeine, SSRIs are almost a given. Marijuana, you know, that's just a herb. And we had no idea. And there was just a recent paper, and I forgot where it was, that probably 50 to 60% of these are also abusing alcohol. So co-addiction is very common. And that's the reason we may need multiple drug therapies to treat the babies. So those of you that are of the senior variety like me, remember that anytime you got a stomach ache, the mama gave you Perigoric. Well, that's because it had opiates. And so it treated what ailed you when it came to the GI tract. And that's where we began treating what we used to begin treating NAS. And that has changed greatly. And this has been some of the greatest changes in the past 5 years in how we're treating babies with NAS. Almost all of us now use oral morphine first. Kind of a life-changing study that just came out of our institution was comparing phenobarb to clonidine. Clonidine is commonly used in adults. Many institutions, our Cincinnati friends, are using that as a second line. What Dr. Burnett and Dr. Brousseau showed was that it really was not a good second line drug. Phenobarbital is the best for that. And then we use clonidine as a third drug. Perigoric is no longer used because it's got a bunch of other stuff in it that's not good for babies. It's mixed reviews, and I think a lot of what we're seeing now is just the papers are coming out that it is helpful. And I think most of us across the country now are using oral morphine. Some are using methadone. Some are actually using Subutex. The problem with these is the dosing. It's easier to dose babies with oral morphine. And most of us now are using a escalation, de-escalation, nursing-led protocols in order to shorter their chain. Problem with Subutex is it's difficult to dose in babies. It's also both it and methadone are longer acting. And so it's, I think, more difficult to treat babies with that. And I think most of us that treat a lot of babies primarily are using oral morphine, phenobarbital, and clonidine. This just shows you the dose. We're not using methadone, never have. Phenobarbital is our second drug, and clonidine is our third. Stay tuned for this. We just don't know yet. This just is to remind me that we used to write on paper, but the main thing about this is that we have protocols so that a baby doesn't suffer, and nurses can up the dose and lower the dose so that we can try to get babies out quickly. The other thing that is what we're seeing now, and it's actually very good, is that we're seeing many women, our moms, that have been treated with Subutex during pregnancy and their dose has been withdrawn. The problem is that it's difficult to predict by the dose of Subutex and whether an infant will withdraw. The lower the dose, the better. And so we're seeing more and more women that we don't see babies withdrawing early, but the problem with Subutex and methadone is that some withdrawal may not happen for 3 to 5 days. So we are observing, in our institution, we observe babies 5 days. That causes a problem with the hospital, causes a problem with mom, but we don't see it. We don't want our babies to withdraw once they go home. Barbiturates can be much longer. Methadone withdrawals almost regardless of dose. And if you know, most of the methadone, the doses go way up 100, 120 milligrams during pregnancy. And the other problem with discharge is that you need to make sure they're going to primary care providers that kind of understand the disease. So how do these babies do? Stay tuned. We began following NAS babies in our developmental follow-up clinic about 2 to 3 years ago, when our school people and our own clinic started saying, you know, these kids just aren't right, you know, having anger issues at 2, they're very difficult to their parents. So we know we do Bailey scales, we do Daisy scales, but there's so many features as to who do they go to, who are their caregivers, what's their socioeconomic status, that it's sometimes become difficult. One of the interesting things we saw out of this is that they have an increased incidence of torticollis, which is where they have wry neck, the neck to the side. The other thing that we found is that these babies have smaller head circumferences, even those treated with Subutex. So stay tuned on this, but we're very concerned that there may be some adverse effects, especially with higher executive functioning and with behavioral functioning and state functioning. If you look at alcohol, it's the worst. You know, small heads, CNS dysfunction. You know, these kids are very special and have a low IQ. Cigarettes lead to preterm birth. You know, they lead and with obstetrical complications, and you know, it varies anywhere from 20 to 30% of women in East Tennessee smoke. Marijuana, we're not real sure, but we are very concerned, and it is still a drug that ACOG is concerned about, especially with impaired executive functioning. And, you know, this is something that we're coming to find out that ACEs, acute childhood events, lead to. So the marijuana, you know, for my generation that brought it to you, you know, these kids, we're concerned still it may not be a safe drug during pregnancy. These other drugs can lead to some even cleft palate. The stimulating drugs, amphetamines, cocaine, leads to behaviors, can lead to problems with urinary tract, can lead to problems with the GI tract, can lead to stroke. So though they may be easier to treat as withdrawal, they may lead to problems in the fetus that can be very severe. Good news is hallucinogens is my generation, not as much a problem, but you may see more of these. I've been reading recently about they're beginning to use some of these in the treatment of depression and other severe problems in moms. So this may be another problem again. And this has been the major problem of East Tennessee is with narcotics. We know, it's very interesting, we know that babies on narcotics don't move as much during pregnancy. We know that they have increased perinatal mortality, NAS, sudden infant death. We're beginning to know that this may be a epigenetically passed disease, and that we may be forever changing their brains to being much more likely to be an addict later, and that they are born with smaller brains. Thank goodness the flu huffers and all that seem to be taking a back seat. This to me is the key of getting moms and getting people into comprehensive behavioral substance abuse care settings prior to pregnancy. Preconceptual care is very important. So what does that mean? That we've got to increase the ability of women to be treated for their drug abuse, and especially women that are on Medicaid and TennCare. And that's a societal problem that we've yet to really address. It's getting better, but we've got to suspect that before pregnancy and treat it. Women often don't access treatment due to financial barriers, social stigma, fear of losing children, family. Also, many women are caught in the cycle of trauma with spouses and other things. And a high mama sometimes is easier for their high husbands to deal with. So we've got to get our women into treatment early. The other thing is that it's got to be multidisciplinary. You know, medical treatment is just a very small portion of the treatment of the addict. I do think that skilled OBs and maternal fetal medicines are critical because they understand the physiology and how to dose the medical MAT treatments. But good old-fashioned AA, NA group therapy and treatment centers is essential to good care. You know, we have some, it's one of them, it's a difficult gig. Nobody wants to take care of a pregnant addict for many reasons. We have a Great Starts in Town, which is an incredible program of treating moms before pregnancy in a area where they can live and stay even after pregnancy. But there's only, I think, about 25 or 30 beds. My church has a place called Susanna's House, sponsored by Cokesbury Church, where they deal with pregnant women, and they're moving toward an inpatient, but not yet there. It's hard to get women into treatment, especially inpatient treatment, because people are fearful for detoxing them. We now have a program here at UT Medical Center run by Dr. Towers, where they take referrals to detox women during pregnancy. Many women do need help. The main reason that I see from this is to get them off street drugs into a reliable way of taking that. You've got to continue to screen them. You've got to continue to look for polysubstance abuse. There's not a whole lot to treat cocaine except stopping it. And again, you need to have good OBs or MFMs in a rehab program and extensive behavioral health. There is, you know, there's a saying in AA, you got to change your play dates and your play things. You got to change the way you think. You've got to change who you hang out with. You got to change where you live. Use increases after pregnancy, often because they go back to the same places where they began using drugs. Increased in postpartum depression. You know, we've got to make sure that they go to inpatient and outpatient treatment centers and behavioral health centers. I would like to see that and we refer all women to Child Protective Services, social work services. And my envision of DHS is that it is, it's not a punitive system, but it's a way to make sure that there is an accountability system once mothers go home, that they're getting into parenting programs, that somebody is looking out after these mothers to make sure that they're going not only themselves, but their children to the systems they need to stay sober. And so my goal is to have, you know, the foster care system, the judicial system, DHS system, medical system, all working horizontally and not vertically to where these women, as they move through pregnancy, have the services that they need to stay sober. Because if not, we're going to be I'm going to be giving this talk on my, while I'm in the assisted living home 20 years from now. So what about preterm babies? With preterm babies, it's hard to diagnose in AS. We've had babies that the first sign that we have is a seizure. So it's very difficult to treat their NAS. Our nursing staff is very good about it, and we have treated babies, but it's difficult to treat them, and it's difficult to know how much and how often. All the tools for term infants, some new stuff, exciting things we're trying to do with our engineering friends at looking at things such as heart rate and movement rates and other things, more biophysical things rather than the typical signs and symptoms of NAS. This is my bibliography, and I thank everybody for listening. We've got a little time for questioning. Come at me.
Thank you, Dr. Gaylord. Folks, you can either unmute, I think. Dr. Berkeley has given people the ability to unmute, or you can just post a question in the chat box and we can answer them that way.
They can unmute themselves.
Okay, thank you.
In that chart where it shows that 2014 was kind of the peak of, you know, the NAS babies, is that just in Tennessee or is that nationwide?
What was the chart of Increasing incidence, is that where you're?
Yeah, in 2014, it had the peak of the baby.
Ours. That's Tennessee. That's
Yeah, that's what I
about
thought.
the time it became reported. And there are, I don't know how many states actually have it as a reportable disease, but it was very helpful to us because it helped localize pockets. It helped us to see if anything that we were doing was making, was progress or non-progress. So I think it was helpful to make it a reportable disease. It is de-identified, and right or wrong, good or bad, I hope that it would be a way that eventually, if moms are diagnosed and their babies are diagnosed, that would be the target system for getting them the help that they need. I have a question about the Bayley scale. The Bayley scale looks at it looks at motor function, it looks at intelligence function, and it is a way that is, I mean, they were doing Baileys when I was a resident, and that was when dinosaurs walked. And it's a way to quantify a child's development. The DAISY scale, it was developed by some people in a lot of work at Vanderbilt, is a way to do a quick year at a year and early on. Bailey's really start at 2 and 3. So it's a way to try to give cognitive and function to compare. Clonidine still needs more trial, yes, but we think that we may have answered that. It was just published in Journal of Perinatology about 2 months ago, as that it is not as helpful as phenobarb as a second-line drug. The problem with clonidine is that phenobarb has been around since dinosaurs. There's some concern about phenobarb and long-term effects in child, but it is still used in seizures and other things as a drug that we know and trust. We don't really know clonidine about long-term effects of clonidine and how, what a kid that's 3 years old or 4 years old. We're beginning that and looking at that in our development clinic. The other problem we don't know with clonidine, it's a blood pressure drug. It's used to treat hypertension. So you have to be careful as you're weaning the drug and watching the drug. So it's not a drug that I would send a baby home on. And it is something that what we do is our phenobarb, we send mothers home on a month of phenobarb with a withdrawing scale. So they're off of, the baby's off of that in a month's time.
Your chat questions, looks like.
Do I have a problem with drugs, alcohol, and clients' history, parents? I'm not so sure I understand the question. I think there are other scales for addiction, and I think that you need to use a scale for addiction because addicts sometimes are not as truthful as they should be. And that's why we do screens. We do screens on probably 90% of all women that deliver at UT Medical. This is not a disease of the inner city Knoxville. This is a disease that goes from East Knoxville to West Knoxville to North Knoxville to South Knoxville. And I've taken care of mothers that, that my kids went to high school with. And so I think you have to have a high index of suspicion, but most moms are pretty reliable. And they want their babies to do well.
Go ahead, Debbie.
I have a question. Can you hear me?
I see the second question about drug addicted babies. That's why I just changed. The terminology has recently changed to exposed neonates, opiate exposed or OENs. I don't know that they're not born addicts. And that's my concern, is that they are born withdrawing from opiates or cocaine, etc. I don't know yet, and I'm very concerned that their brains maybe have changed to an addicted brain. And I do think that there is, number one, and we know this, there's a genetic, it's what's called a disease. There is a genetic predisposition, as there's a genetic predisposition to cancer. Doesn't mean that if you have the cancer gene that you're going to get breast cancer or colon cancer. It's more interrelated. But we also know that it may change the brain of these babies to where they may be more likely to become addicts. So, you know, a lot of addicts will tell you, I was an addict when I was 6. I just didn't know it. You know, I had the tendencies and the things that go along with alcohol addiction or drug addiction when I was young. But I just didn't use drugs then. So I don't know that. I think it's a very interesting concept. So stay tuned. That's where we may begin better treatments of drug addiction, is when we can do like a colon screening, or when we can do a genetic test and say, Mark Gaylord has, you know, his dad was an alcoholic, his gene X1Y shows that he has a high likelihood of being an addict, and we should maybe counsel him in his primary care visits that he shouldn't drink or he shouldn't use opiates. The other thing that's very interesting about addicts is that though there is a lot of cross addiction, many addicts are very drug specific, and they will tell you, the first time I used alcohol, I knew that I was an alcoholic. First time I used opiates, I knew that was my drug. So that makes me think that there is something inherent in their brains that is different. So I think that's the most exciting part of where drug addiction and drug treatment will go, is that we'll get, like we do, you can do now a cancer profile that says, you know, you have the OYGD gene, and we're going to use this drug to treat your cancer. And I think that we may eventually get to that with drug addiction.
Any other questions?
SAMHSA, yes, that's a great, I'm sorry, I didn't mention that. I was lucky in my career to go to SAMHSA and actually hear Dr. Finnegan talk, and that's you're correct. It's very helpful. And all this data about the state data, all you have to do is go to Tennessee Department of Health, and it's and just put in NAS, and it's there. The 4 Ps will be on the slides that I think Andrew will have available to everybody. Is that right, Andrew? I put him to sleep. Yeah.
I think he's caring for a baby right now, actually.
Oh, yes. I'm sorry. That's COVID. Yeah.
Yep.
Yeah, I will. If you send me an email at coe@utmck.edu, I will make sure you get the slides.
Yeah. Or to Drew.
Yeah, and
get it to Karen. Either way.
You know, this is something that I think we need to all be advocates about, advocate for our moms, that we need to try to increase our treatment centers. We need to try to increase our prenatal treatment of moms. I'm the canary in the mine, and that by the time they get to me, almost any disease, when I start seeing GI distress in my babies in the NICU, I know that there's been a huge virus outbreak in the community. When I start seeing COVID in the nursery, COVID is rampant. When I start seeing NAS in the nursery, it's rampant. So we're the canary in the mine, and we're kind of the end of the funnel.
All right. Well, thank you again, Dr. Gaylord. That was very informative. We appreciate your time, and thank you everyone else for logging in. Look for the certificate in your email. Karen, anything else?
No, just go to the link that was sent to you, fill out the survey. We appreciate you filling out that survey. That helps us a great deal, and you will be emailed the certificate that you can turn in for your hours.
Thanks, guys.
Thanks,
Thank
everyone.
you. Bye.
Thank you all. Bye-bye.
Bye.
Bye.